So thank you everyone for being here with us tonight for our webinar, Psychosis, Early Signs, Diagnosis, and Treatment, presented by Elizabeth Roof. Elizabeth is a senior research associate at Vanderbilt University Department of Psychology and has been a licensed health service provider in Tennessee since 1994. What were you, 14?
Love that. No.
She currently directs several research programs with children and adults with PWS with Elizabeth Dykens. They've published many peer-reviewed journal articles and have been working and following longitudinally over 400 children, teens, and adults with PWS and research studies. It's my pleasure to introduce to you Elizabeth Roof. Thank you for being with us tonight.
Awesome. Thanks, everybody. All right, I'm going to share my screen now and show my slides. I'm excited to talk about this. I think people have a lot of questions about this, so I'm going to share my slides. Let's see. Okay. So I'm going to be talking a little bit about psychosis and PWS, and my thought is it's kind of informal. I am not a psychiatrist, and the first thing that I'm going to talk about is well, it's not advancing. Hold on a second. Okay. So I'm not a prescriber or your child's doctor, so you should always run everything that you're going to do or thinking about by your child's doctor. Not everything I'm going to say is going to apply to you and your child, so just kind of take that with a grain of salt. Take what you need, leave the rest. This isn't a talk to diagnose your child. You know them much better than I do. And I'm happy to talk with families and help with next steps, but I can't treat people and I don't see patients in any other way except research studies. So and also to kind of know that there are very few PWS psychiatric experts, so you may have to adjust your expectations. Everybody likes to think there's this just incredible network of psychiatrists and other people who are going to be able to see your kid, but the reality is that does not seem to be the case. So you sometimes have to look at pediatricians and neurologists and nurse practitioners, and you might even have to find just a regular internal medicine person, but you might find somebody who knows your child well, is willing to learn, is willing to talk about what kinds of things we know work for this population. And again, I'm always happy to do consults with those people. But again, I think it's really important to note that there's not a ton of people in this space that actually take insurance, see a lot of patients, and would be able to see your kids. So again, I think it's really important to have realistic expectations. I don't know why this is not advancing the way I think it should. Okay, hold on a second. Okay. So what is psychosis? People talk a lot about it being crazy, right? So my kid's crazy, my kid's acting crazy or whatever else. And so we're going to talk a little bit about what psychosis actually is, some of the symptoms, and then we'll talk a little bit more about treatment and some of those other things. So it really is a break from reality, seeing, believing, or hearing things that aren't real. We don't see a ton of people who have visual hallucinations, but we often have people who talk about hearing voices. And sometimes it's really perplexing because sometimes with people with PWS, and you all know these kids, they can hear when you're talking about them from another county, right? So when they'll sometimes say, I hear people talking about me, I sometimes talk to parents and other providers, and sure enough, they are talking about them. Maybe not to their face, but the kid is hearing some of those things. We try really hard to figure out what is kind of odd thinking and wonky thinking versus what is more kind of PWS thinking. And they've got great hearing. And if you're talking about them, they're always quite interested in that. So again, odd thoughts that aren't based on facts or real experiences. And they often kind of veer towards the more paranoid or fearful, like a feeling of being threatened. People are looking at them, talking about them, wanting to hurt them. Those are the kinds of odd kinds of preoccupations and thoughts we often see. Unfortunately, anybody with an intellectual disability has some of those odd thoughts to begin with. I'm going to talk a little bit about the progression of this is more kind of normal PWS behavior, and this is where it kind of gets to some point that we may need to intervene, look at medicine, maybe evaluate for something that is psychosis. But again, it's often a more fearful, paranoid kind of like presentation. And in PWS, it's often not related to schizophrenia. Like people like to throw that word around and bipolar and other kinds of diagnoses. We often don't see any family history of any psychiatric, big psychiatric features in families. In the general population, the prevalence of psychosis is 1 to 2%. And people with PWS, it's markedly higher than that. But I'm going to talk a little bit about what those risk factors are. And in those with PWS, sometimes it's really hard to tell when they're hearing or seeing things. They're not great reporters. They often don't know when it happened, what happened, lots of details. they're not good at being insightful and thinking about reporting things in an accurate manner. So sometimes we have to kind of get down on their level and really talk about things in a way that they can say yes and no to, versus ask them open-ended questions where they're like, I don't even know what you're talking about. So, and most people with psychosis don't know they're sick. They don't think there's anything wrong with them. People are scary, people are mean, these things are happening to them. And so they don't often seek help. They don't tell you that they're feeling freaked out or worried or whatever else. You just seem to notice and notice the behaviors. Unfortunately, it's often missed by professionals. They'll say stuff like, well, it's just PWS. Sometimes it's not PWS. Sometimes it's something else. Just like you can have PWS and autism features, you can have PWS and psychiatric and psychotic features. So it's really important to know that there's core features of PWS, and then there's something that's kind of out of the realm of normal. And when it's out of the realm of normal, that's when we want to intervene. In people with PWS, the psychosis can happen really quickly. And often there's a trigger event when it starts. I had a young man just recently that his parents were telling me about his psychotic break. And what was interesting, he had been at some kind of family picnic or something like that. There were fireworks, it was dark, there was a lot of chaos. And when parents finally found him, he kind of hid, he got freaked out by all the noise and whatever else. Within a few days, he was having a psychotic break. We don't really often know what the trigger event is, but sometimes you will find something that happens to them that is very stressful, very fearful, and they kind of interpret in a way that's really kind of odd. And we can't really decide if it's a chicken or egg, right? Are they interpreting it odd because they're psychotic, or is something happening to them that makes them psychotic? So again, I try really hard to figure out what those trigger events are because it helps me figure out what's going on. Some of the risk factors that we know are people with UPD, right? We talk a lot about people with UPD are more likely to have a psychotic break. There's something Deepan Singh has written a really nice book about neurobehavioral aspects of PWS. And one of the things he talks about, I think there's a 40% risk factor for people with UPD to have psychosis over their lifetime. Doesn't mean everybody's going to get it, but it does mean that they have a higher risk for that. The other thing that people need to be aware is if you have imprinting mutation, you too have a lot of the same features as those with UPD. I have seen a fair number of people with imprinting mutations that have also had psychotic features. So it's just important to know that you don't go, oh, my kid's a deletion, I'm off the hook. There are people who have other subtypes that often have psychosis, but it's just more common in people with UPD and imprinting mutations. We often find medications that are very stimulating, like some SSRIs. Prozac is one that I see pretty frequently at high doses that can cause a psychotic break. Sometimes ADHD medications can. We have people using them off label. We have people using them sometimes as adults. We sometimes have doctors who are using ADHD medications to help people lose weight. I had a young lady who started taking Vyvanse, which is a really long-acting drug, and it's really effective for people with ADHD. Her doctor was giving it to her to help her lose weight, and within almost 2 weeks, she became floridly psychotic, and she stopped taking the medicine. She was hospitalized. She went on a medicine that worked really, really well. And her mom said, but she was so thin on the medicine, I want to go back to it. And I'm like, why would we do that? So we do know that there are certain medications that seem to precipitate some of these psychotic breaks. Sometimes weight promoting agents can do the same thing. I've seen it with Provigil. Again, not common, but it does happen. Or even other high doses of common PWS medications. So it's important to know that if your kid's taking a medication and they're on a high dose, it is possible to actually kind of create the perfect conditions for psychosis to happen. But what we often see are changes of environment. School, work, or home relationships, something changes and the kid takes it really hard, right? They seem to be very affected by it. It can be a loss of an aide at school. It can be a change in the home, older sibling moving off to college, not going to college, siblings kind of passing them by when it comes to growing up, leaving the house that they grew up in. Those can also be things that are really stressful events for them. The stressors for them are not your stressors. So we worry about money and our job and our relationships and things like that. They sometimes are stressed by things that are kind of unusual. The death of a pet, the loss of a pet, the loss of a really close friendship, especially sometimes adults who are in supporting roles like teachers and aides or therapists. They can get really attached, and losing those relationships will sometimes put people in a tailspin, and we'll sometimes see that those are the stressors that really affect them. And it's ironic because parents worry about deaths of grandparents and deaths of other like people, like, extended family. People with PWS are pretty, I think they're pretty practical about stuff like that. I had a young lady whose mom was talking about the grandfather dying, and she was very concerned. Brought her daughter to see me, talking about her worry that the grief and the death of this grandfather was really going to affect her daughter. Ironically, when I talked to the daughter, it was really kind of funny. She says, "Well, I miss my grandfather," but she said, "And he made the best pancakes every Saturday morning." What she missed was the pancakes. She loved her grandfather, but she loved the fact that he fed her. And we were talking about the fact that for some of our folks, they don't have the same relationship with people that we have. So if we're grieving, we have to be really careful about not putting that on them. And also age. As people get older, sometimes relationship change, living situations change. Those can all be stressors. So it's important to know that they can be. How common is psychosis? A few years ago, some studies were saying 80 to 90% of people with UPD would become psychotic. We were really surprised to see that because we saw a fair number of people with UPD who had never had a psychotic event. So what we find is if you ask a bunch of questions that are kind of broad, it's almost like taking a magazine quiz or something. Amazingly, everybody has ADHD or everybody has this thing. We find that a lot of people meet criteria, but it's really important to do a very detailed psychiatric history to get all the symptoms and whatever else, and sometimes you can tease that apart. When we did that, we found several people with psychosis who didn't have UPD, and nobody really talked about them for a long time. They're becoming a little bit more aware of other subtypes having a risk factor for psychosis. We had 8 people who had active psychosis while they were here. Literally, the person that we saw was actively psychotic. Parents were unaware. Sometimes their mental health professionals were unaware. And then we had another 28 that had a past history. They'd had a break, they were being treated with medications and were doing quite well. That is the kind of the course that goes along with PWS. Psychotic break, sometimes hospitalized, medication, whatever else, that goes away. Sometimes people stop taking medications, sometimes they try other medications. There's sometimes things that happen that we don't anticipate. And then those psychotic features will basically come back. So it's really important to kind of know if you're taking a medicine, as I always say, if it ain't broke, don't fix it. So if it's working, don't take it away. But we found a fair number of them were partially or fully resolved out of 175 patients. But we did find lingering odd thoughts. They have a weird obsessive quality to like their relationships with people. And I'm sure if you have a teen or an adult with PWS, you're used to them asking odd questions about, their physical therapist or their teacher. They want to know a lot about them. They may kind of stalk them. They might want to Facebook friend them. They get really attached to people. And so again, we sometimes see those lingering odd thoughts. Also more common with people who have autistic-like features. They don't have to be diagnosed with autism, but those who have autistic features are more likely to have that kind of like really odd lingering thoughts that don't seem to be true psychosis, but seem to be kind of strange. And we're going to talk a little bit more about that in a minute. So psychosis in PWS occurs often. If it's going to happen late teen years to early 20s, it's a time of a lot of transition, right? School is changing, they're often transitioning into community settings or in their like working places or, volunteering or whatever else. We sometimes see some of those things well, and some of them are later. So it just really depends. But when people ask me about 4 or 5-year-olds, being psychotic, I'm not saying it couldn't happen. I just have not seen it. So I just think it's important not to worry about your 4-year-old who has an imaginary friend as being psychotic when it's probably developmentally appropriate for them to do that. Same thing with believing in Santa Claus or the Easter Bunny or whatever else. A lot of times they have those developmentally much younger kinds of behaviors, playing with baby dolls, talking to them, thinking they're real babies, that kind of stuff. That to me still is developmentally appropriate if their IQ is kind of in that range where you would expect that. So it's important to know that those are not odd behaviors developmentally. We're looking for things that are different from their baseline. So again, what we often see is precipitated up by stress, loss of a friend, sometimes a boyfriend. We have found that dieting, like really significant dieting, will sometimes throw people into a psychotic break. So I'm not saying you don't diet, you don't limit food and do whatever, but you have to be really careful of watching some of those behaviors because people who are losing weight with PWS feel sometimes very like physically distressed, and that can also sometimes lead to that. So again, school home changes, worries about different things, transitions from one thing to another, one school to another, a home to another, moving, those things are very stressful for them. Depression and anxiety is a common cause of psychosis. So you often see depression and anxiety before they become psychotic. They worry about things. They ask you questions over and over. They need to know lots and lots of information. And yes, that sounds a lot like PWS in general. You're looking for something that's different from the way they normally are. So it doesn't mean that they don't get stuck on things if they've always been that way. But if it has a different feel to it, then you want to take note of that. End of school is a really big loss. And we found for a fair number of people leaving school and being at home all day. Lots of states don't have services. They don't have anything for these people to do. They're living at home. There's no residential treatment centers. There's really not much for them to do. We find that when they're engaged and active, they're doing good. And when they're at home all day with lots of unstructured time, they're not doing good. I always say that downtime is don't time for them. They don't do well with things that aren't structured. They often look disorganized. I tell people I can often see people come into my office and I'm kind of like, their hair's all crazy. They haven't brushed their teeth. They just look unwashed, disorganized. Their clothes are very messy, just really different. And so I look for that stuff. Changes in sleep, changes in diet, changes in thinking, and delusions that are like odd thinking that gets bigger and more severe. So it's no longer a interesting little kind of aside. It becomes the focus of all of their attention, especially if it's about another person or something that's happening and they just get really, really stuck on it. You need to be on the lookout, monitor for these symptoms. Again, when dieting is happening or other stressors occur, I don't want you to be like totally like just like looking for it. But at the same time, we have people who miss it. I have people I see that sometimes they've been psychotic for 2 or 3 years and no one's done anything about it because they just go, that's PWS. You need to really act quickly and be relentless. You just don't need to, if people tell you, oh, that's PWS, or don't worry about that, that'll go away. Don't take no for an answer. Really, really pursue it. And we think that the sooner we actually treat them, the more effectively we actually treat them and more likely them not to have another psychotic break. So again, I think it's really important as a parent to trust your gut. Look for changes. Don't chalk everything up to PWS behavior. I've had so many people who have been psychotic for years and people will say that's just PWS. And it's really not. Look for other losses. Again, loss of a pet is a really big deal. I've had more people who've lost a family dog, cat, whatever else, and it seems like a very odd preoccupation. But here's the deal. If something can happen to something that they love so dearly, then they start to worry that something can happen to them. So again, it's just almost like a an association of like what that means to them. And honestly, and if you've seen this, I know I have, they love animals often more and intensely than they love people. So I had a young girl who was crawling on her hands and knees trying to get some campus cat to come to her. She literally went to the CVS and bought a can of cat food at lunch to feed this cat and was literally trying so hard to lure it so she could pet it. So they really are attached to animals. So just know that it may not seem like a big deal, but sometimes it's a huge deal. Schedules and consistency can really help a lot with recovery. So this idea that planning meals, planning activities, planning the day, and not letting them sleep all day, up all night, doing kind of whatever. I think we always think, well, we don't want to push them, but at the same time, not having schedules and consistency can make them more impaired and more ill than keeping them on a schedule. Again, sleeping, eating on a schedule, and regularly scheduled activities. You have to kind of plan so that they're not too much and too overstimulating and just like too much expectation. But at the same time, it is really helpful to have a daily kind of schedule when people are not doing well psychiatrically. So having supervision, grabbing outside help if you can, respite care, you will find that doing this day in and day out is exhausting. So you don't want to lose all those reserves that you have because as a parent, this person is usually not the only thing you're having to take care of. So you got to take care of you too. So knowing that sometimes you're going to be dealing with psychiatrists, psychiatric hospitals, inpatient treatment, sometimes that is what's needed at that point to help your kid be okay. So knowing those things is really important. Nobody wants to put their kid in a psych hospital. I have worked in one. It is not a place I would want my own children or myself. But when your kid is that impaired and you're concerned about their safety and their risk of hurting themselves or getting hurt or hurting someone else, then you got to do whatever you got to do at that point to keep them safe. Take breaks if you need to. It's really exhausting and it's very stressful. And I have parents that are just treading water day in and day out. And again, it's really exhausting doing this. Find things to help support you on your journey. They may be psychotic. It hurts parents way worse than it hurts the person that it's happening to. I think it's distressful, but watching somebody lose touch with reality, talking to people who aren't there, being so paranoid, so threatened, and so fearful is really, really stressful. So kind of know that you need to take care of you. I talk a lot about baseline, but knowing what your kid is like day in and day out, what are the core features? We all, as humans, have core features in our personality, right? Some of us are outgoing, some of us are more, kind of they're a little bit more of an introvert, or some people have things that they like to do over and over, and other people like all new activities. Knowing what's normal for your kid day in and day out is so important. And don't let anyone tell you, you know your child better than anyone. If your gut says, hmm, this feels weird. This feels different. Listen to your gut and ask yourself, have I seen this behavior before? When? Where? Is it ongoing? Is this something that we've seen in the past? Because when your kid gets stressed, you can sometimes see coping behaviors or soothing behaviors, ripping paper, going through books, doing things over and over. And my thought is if that's what they normally do when they get stressed, that's not concerning. If you wake up at 2 o'clock in the morning and your kid is up and they've been up for hours and they're doing those things, then you may think to yourself, this is not usually what happens. My kid's a good sleeper, my kid's a good eater. And when they don't do those things, then you start to worry. So, how do they cope when they get upset and anxious? What kinds of things do they do? Do they cry? Do they self soothe? Do they find things, again, doing them over and over? Do they find that soothing? And again, if they do, that's fine. I had a young girl who liked to take string and just wrap it around her finger. Her teacher said, well, that makes her look so impaired. So I'm taking the string away. Within just a few weeks of not having that, this girl was falling apart, crying, going home from school every day. And she really ended up having a huge psychiatric issue at that point. So again, self-soothing is fine. If I always say, if it's not bothering other people, it's okay for them to do it. So what is their normal sleeping and eating pattern? Most people with PWS sleep really well. Sometimes 10, 13, 14 hours. That's how well they sleep. So again, if that's what they normally do, but then your kid is waking up early in the morning or can't go to sleep at night, then you need to start worrying. And I'm going to talk a little bit more about sleep because it's such an important predictor of psychosis. Do they seem withdrawn? Do they seem more apathetic? Do they seem more disorganized? And when I say disorganized, they can't follow through. It's hard to get things done. If that's their baseline, that's normal. But if it's not something they've normally done and they're struggling, then at that point, we really want to tune in and figure out what's going on. Once you know what's normal, how is this behavior different? That is the key. When I see people, it's hard when I've never seen them before and they're only psychotic. I have to really tease about what they might have been like before. But for a lot of psychiatrists, all they see is your kid in that moment. And they're like, well, this is what they're like. You need to make sure that you let that person, that provider know that that is not what they're normally like. They are normally pleasant, cooperative, they get along with people, they have friends, whatever you can tell them so that they understand this is unusual behavior. So psychosis and PWS really does look different. Having seen people with schizophrenia and people who are having psychotic breaks, I know what that looks like, but this really does look different. And what it often starts with is changes to sleeping or eating. So when we see people who are eating less, like parents will say, well, normally he's standing at the kitchen door just waiting for, me to put food on the plate and he's just waiting. But I'm having to call him. I'm like, hmm. Or again, waking up early in the morning, waking up for several hours during the middle of the night. They may not wake you up, but they're awake, they're on their iPad, they're reading, they're something, and then they go back to sleep and you see them tired during the day. That if that is not their baseline, that is unusual. And that's pretty unusual for people with PWS. Again, social relations. If you notice they're less likely to talk to you in the morning or hang out with you and they're just in their room and they're isolating themselves and they seem withdrawn, then again, if that's not their baseline, then you want to keep an eye on that. Again, you may have a trigger event. For several people, it's been loud, kind of like chaotic things that somehow has triggered this psychotic event. So again, I'm not saying you don't do that, but just be aware where your kid is. Talk about expectations. Maybe they have head over the ear headphones. Like, what kinds of things can we do to make this less overstimulating, less stressful, and a little bit easier for them to do that? Often it just seems like you start out with the sense that something seems different. Trust that instinct. I have parents who have kids, again, who've been psychotic for a while, and they're like, well, I thought something was different. And then they got used to the way that the new different was. And I'm like, Nope. You got to trust that, and you got to get help. And so again, changes to self-care, to grooming, to be part of an activity if they play t-ball or Special Olympic swimming or basketball or whatever else, and they're like, I don't want to go, or that person's mean to me, or this person, like, and they go on, and it seems like it's such a negative event, and it used to be something they really enjoy. Lack of enjoyment in normal activities can be a real precursor to something that's happening. But again, I often see the grooming, the self-care is being a real kind of marker, and they look tired. They look disheveled and tired and exhausted. And again, that makes me wonder, could it be psychosis? Maybe withdrawn, less likely to interact with peers. You sometimes see negative behaviors go away, and people are like, yay, they're no longer skin picking or they're no longer food seeking. I'm like, huh, that worries me, because that is a very genetically driven behavior. So if that goes away, is it possible that something else is coming up that is going to be a big problem? And again, sleeping less than normal. So again, sometimes it's sleeping more, but most of the time it seems like it's sleeping yet less. Most of the parents that I talk to who have a kid who's gone through a psychotic event will say the first thing they notice is the kid is waking up really early in the morning, 3, 4, 2 o'clock, midnight. They're up for hours. That is concerning. Carrie Bearden did a really cool study in PWS looking specifically at these kind of early symptoms and causes of PWS psychosis, and found that sleep was the biggest predictor of people who are going to be psychotic later on. So I think that's really huge to know. Sleep, we know in general, is so important for mental well-being. We all know when we don't sleep, we're irritable, we're inflexible, we're grumpy, we're all those things, right? So for people with PWS, they need a lot of sleep. So when parents will go, well, he goes to bed at 7 and he wakes up at, like, 5 o'clock in the morning, and people like think that's so odd. I'm like, that seems like a pretty normal sleep schedule for somebody with PWS. They do sleep more than their normal peers. So knowing that sleeping 8 hours a night when they used to sleep 10 or 12 hours a night, that is something we need to be aware of. And again, the early morning awakening can be actually indicative of depression, and that too can lead to psychosis. We often see anxiety and depression as the first symptoms of psychosis. More worried, more stuck, more perseverative, just really seeming to get like stuck on a thing and really can't stop thinking about it, worrying about it, fretting about it. So again, those things as well. Not sleeping also leads to increased emotional reactivity. So the deal is you have stressors, you're sleeping less, then that stressor seems bigger. And it just becomes the big, big self-fulfilling prophecy of really struggling with feeling like you've got it together when you're not sleeping and you're not eating well. Again, that increased disorganization, not getting things done, not following through on things. And again, if it's different than their baseline, then you need to worry about those things. They may be more tired, and they can really have a hard time letting things go. So any perceived slight, anything that you say can be, why are you so mean to me? Why are you yelling at me? And yes, people with PWS do that. It's got a different and more intense flavor to it at that point. So what we think is there's this kind of like core PWS symptoms. So in general, they have some of these confused and magical thinking, right? Believing in the Easter Bunny, believing that I had a young man who would open up his yearbook and he would sing and talk to the people in his yearbook. They weren't there, but they were in the yearbook. That's not psychosis. He'd been doing this for years. So we're always trying to figure out what is baseline, what is their normal behavior versus what is something new. Poor attention is pretty common as a baseline feature. Perseverative thoughts are pretty common, and getting stuck. Those are what we already know are the core features. Looks a little bit like psychosis, but it's not there yet. Then you add those negative symptoms, becoming more isolated, more withdrawn, fewer interests, no social outlets. Again, they start to like kind of withdraw and really focus inward. And so whatever's going on in their head is so big that whatever's going out in the outside world just can't compete. Enjoys, very little things that they used to enjoy before. And again, unstructured time. Then we add the stress and the positive symptoms. They'll often say people are looking at them, talking about them. They think others are judging them or criticizing them. And sometimes they're not wrong. So I try really hard to figure out what's real and what's not real. They will sometimes hear voices that aren't there. And what's interesting is for people with intellectual disability, the thoughts that they think, they often don't know. And what one young man was telling me about the voice that told him about his parents and all these really awful things that he should do to his parents. And I finally said, who does the voice sound like? And he goes, it sounds like me, but it's definitely not me. And I'm like, okay. So at that point, he's obviously psychotic, but he couldn't quite figure out that the thoughts he was thinking, he actually attributed them to an outside voice. So again, it's sometimes with an intellectual disability, it's a little harder to tease that apart. But when they become threatening and scary, like people with PWS often talk to themselves, you'll hear them in the room just having a conversation. If that is normal and they're processing the day's events, like I went to school and my teacher said this, and they'll often replay what people have said and done, they've heard, and they're always the boss, they're always the teacher and in charge of all things. But if you start to notice that they're starting to argue with the voices or it feels threatening or scary, then you want to intervene because usually at that point something else is going on. What do the delusions tell us about? I think a lot of times, again, the fact that paranoid, fearful for safety. I had a young girl who her parents at one point noticed that she was waking up in the middle of the night. They came in to actually see what she was up to and found her actually under her bed, sleeping under her bed. And they're like, "What are you doing?" And she said, "I can hear people scratching trying to get into my room. I think somebody's trying to break in and hurt me." They look around, there's no evidence that any of these things are happening. They don't hear anything, they don't see anything. She had been doing this for months and was so worried that someone was trying to hurt her that she said that I have a hard time going to sleep. When they start to become fearful for safety or that somebody's going to hurt them, that makes again me think, could this be psychosis? Worries about being humiliated or embarrassed in front of other people. They generally don't seem to notice sometimes when they are being humiliated or embarrassed. So when they notice it and they're really picking up on it, then you want to be aware that this feels different. Obsessions with other people. I had a young girl who became really psychotic and really distressed after she left school. She started thinking she saw her teacher in different places. Her mom would be driving down the road. She'd go, "Look, it's Mrs. So and so in that car." And her mom would look and she goes, "Huh." She would look and she's like, "I never seem to see her," and whatever else. And then at one point, I'm thinking, how can she be all these places? The girl's magical thinking of her teacher who she really loved and missed and trusted, she started to see her everywhere, in strangers' faces, in cars that went by, in people going down the street. She became obsessed. But again, it was a real predictor of something later on. And when the mom finally said, "That's not your teacher," the girl became just so distraught and angry. And at that point, they realized they had a real problem on their hands. Sometimes you see that believing TV and movies are real life, like Twilight or Harry Potter. And yes, it's cool and it's fantasy and it can be a developmentally appropriate thing. It's when they truly believe that Hermione Granger and Ron Weasley and Harry Potter are real people and that like the people are wizards and whatever else. If it takes on a weird turn, that at that point you might want to figure out, is this something that's normal or is this something that's taking a weird turn? I'm gonna tell you a little about a young woman named Alice. And so her residential PWS group home that she was in, I had seen her a couple times before. Lovely, funny, feisty woman. They were really worried because Alice started saying that people were coming into her room when she was at workshop and they were moving things around and that somebody had stolen her father's World War II medal, right? So he'd stolen his medal and they were taking away his legacy. She just kept saying they're taking away his legacy. And they were telling me about this, and I'm listening to it, whatever else. And the first thing that I thought of is like, Alice is 50. There is no way that her father fought in World War II. He would be like 100 years old. I'm like in my head going, hmm. And so they're telling me that. I'm like, okay, well, that doesn't make a lot of sense. And I'm trying to tease apart what's real and what's not. She's very stressed. She's becoming much more withdrawn. She wants to kind of hang out in her room and make sure that nobody comes in here. She's starting to hide stuff in her room and whatever else. And I'm really going down this path with staff trying to figure out what's going on with Alice. And because she's UPD and she's 50, I'm like, okay, this could be psychosis. And I finally asked a question. I said, is there anything else in the home that's different? And they're like, we have a new resident. I'm like, oh, okay. And I go, how long has she been there? And they were like, oh, like maybe 2 or 3 months. And I'm like, does this coincide with Alice's worry that people are coming into her room? And they're like, yeah, pretty closely that and whatever else. Do you think that person is maybe stressing her out or the fact that she's there? And I said, is this person going into Alice's room? And they assured me, absolutely not, because we are sure that she's not. So I said, put up some cameras. Let's check. What do we find? Young resident is going into Alice's room and she is taking stuff and she's hiding stuff and she's moving stuff just to mess with her. Alice isn't psychotic. She has a legitimate concern. And as soon as they got her a lock on her door that the girl couldn't get into, Alice got better. We need to figure out what is real and what is not real. The whole thing about World War II, I have a feeling that she just kind of either made it up or heard a thing and just kind of put it all together, gobbledygook, and that made sense to her. The more troubling thing was thinking that somebody was kind of out to get her. And she said that, I think somebody's doing this just to mess with me. She was not wrong, and she was definitely not psychotic. So I think it's important to know what's real and what's not real. On the other hand, we have Chris, again, a 46-year-old man with PWS, but also a deletion, disheveled, unshowered. And I started to notice the more I talked to him, the odder the conversation got. He actually, within a few minutes, goes, "Oh, well, now I know who you are." And I'm like in my head going, "I've never met you before." Okay. He goes, "You go to my church." I go, "Well, actually, no, because you're in Texas and I'm in Tennessee. So I don't go to your church." And then I like talked to his mom. I said, "Do I look like somebody who goes to your church?" And she goes, "No, I have no idea who he's talking about." That was odd. At lunchtime, he wanted to go to his favorite restaurant in Texas, except he's not in Texas. He's in Tennessee, right? And he gets more and more agitated. And then he just throws a huge tantrum. He's throwing things. He goes, "I think you're trying to trick me." And I was like, "Well, you flew to Nashville to see me. So you're not in Texas anymore. So you can't go to your favorite restaurant in Texas because you're not there." And it's like, he had no idea what I was talking about. Didn't remember getting on a plane, didn't remember anything about this, but this real magical, odd thinking. And then we started like finding other troubling symptoms that were very similar. Up late at night or early in the morning, eating less, losing weight, all those things. And again, this had been going on for more than 2 years, and he was seeing a normal, like a psychiatrist who prescribed his meds, and no one seemed to know that he was actually floridly psychotic. So I think it's really important to figure out what makes sense and to have a kind of a detective kind of like sense to you about what seems normal and what doesn't seem normal. So now that you're worried, what do you do? First thing you do, talk to your provider. It can be your primary care physician, it can be your internist. You talk to whoever who knows your kid well, who knows you. Keep really good notes, times that you see things, days, time of the day, observations. Again, be a detective. Be curious, watch things, notice things, write them down. If you can't keep your kids safe, and I tell people this and they hate to hear, I'm like, I think you need to go to a ER or a psych hospital to get your kid evaluated. I'm like, "Oh, I don't want to go there." I'm like, nobody does. But if your kid is doing risky things, and I've had kids who are so psychotic that they want to hurt themselves because they'll say, "I don't want to feel like this anymore. I don't want to be like this anymore." So again, if your kid's saying stuff like that, you need to take it seriously. It doesn't mean that they have some grand plan. It might mean that they could run in front of traffic. And I've had people say exactly that. "I don't have a plan. I would just run out in front of a car." So again, if they're at risk, you need to take that seriously. Having supervision, structure, having low emotion. I know it's distressful when they're saying crazy things to you, but you being upset about it does not help the situation. So being low emotion, low stress, and having low expectations. It's about getting through your day. It's about doing what you need to get through your day. Don't take no for an answer from a professional who tells you this is PWS. Go see somebody else, whatever you need to do, but take it seriously. Advocate for your child because they can't. We find most kids with PWS don't know they're ill. They can't describe the symptoms very good. And so it's really important for you to advocate for them. And medications are so important. So medications can really help, and they can also prevent future episodes. Just because you're better doesn't mean you should stop taking your medication. So I was depressed. I took an antidepressant. I'm better. I'll stop. Let me tell you, I'm very likely to be depressed again. Same thing for psychosis. Monitor compliance, trust but verify. I had a young lady who was supposed to be taking her antipsychotic medicine. After a psychotic break, she went to a slumber party. She got really distraught. Something happened there. We never figured out what happened there, but something made her really upset. She walked into a retaining pond in the subdivision where the slumber party was held, and that's where her parents found her. She could have easily died. She took medicine. She took it for several weeks when they hospitalized her. And then she started deciding that she didn't really need it. So she was basically putting it in the house plant and not taking it. And within just a few weeks, the psychotic symptoms came back again. So now Her mom watches her take her medicine. She has her open her mouth, lift her tongue, and she watches to make sure that it is gone because she doesn't want her pocketing that medicine. It's important with medications to start low and go slow. You don't want big doses, you want little doses, you want to really treat things. And that understanding that newer medicines aren't always better. They're all splashed across the TV and every, thing that they have is just amazing, except it's not. We have a lot of data on some of the older medications. So more isn't always better, newer isn't always better. We're looking for stabilization, not a cure. We're not going to fix PWS. We're going to hopefully get rid of the psychotic symptoms so their quality of life goes up. Get your whole team together to help in-laws, grandparents, siblings, whoever you can get. This should not be a you against the world kind of thing. You need all the help you can get. And that is true of your professional help as well. Everybody needs to be on the same team, communicating, not accusing people, and not doing other kinds of things that really kind of disrupt the whole working together. Think of treatment like a stool, right? So some people need an antidepressant for mood. They need a mood stabilizer for that kind of like wonky mood instability that just like they're up, they're down, whatever else. And then sometimes they need an antipsychotic that really does seem to help for anxiety, for psychosis, and irritability. Any two things often have wobbly legs. So again, we want to make sure that we have all of the legs, we stabilize things, and we make things better. Not everybody needs all three medicines, but a fair number of people who have a psychotic break do need a mood stabilizer. They need something to help their mood, and they often need something to help them with their psychotic features. So some of the medications that we have some data in and some kind of anecdotal data are old medicines like Risperdal. At low doses, it can be really effective for people with PWS. I've had people who were actively psychotic, and sometimes a week of Risperdal, they're completely clear. So again, it's an old medicine, but it's a really effective medicine. Zoloft can be really effective. Our friends in Germany published a really cool paper looking at really low doses of Zoloft in people with PWS. It can be really effective. Depakote is a mood stabilizer, and it's also a medicine that's used for seizures, but in this case, we're talking about mood stabilization, as well as Lamictal. Those can also be really effective at low doses. We don't want people on high doses. I just talked to a mom this weekend whose kid was on 2,000 milligrams of Depakote, and he was almost catatonic. That's not what I'm talking about. Low doses, go in slow. So the dose is almost as important as the medication you choose. So it's not about the perfect medicine, and it's not about ramping it up to some ridiculous amount because people with PWS seem to be pretty sensitive to medications. Start with the lowest dose, unless your child is actively psychotic, and you might have to do a little bit of a loading dose to get things back on track and then lower it at some point when things get stabilized. I often tell people that people with UPD seem to be more sensitive to medicine than people with deletion. And so again, whatever you start people out in deletion at, sometimes half of that is good for somebody with UPD. So thinking about that really conservative, slow process. If you see improvement, that's great. But more medicines isn't always better. I have people who go, oh, I'm just going to tweak it a little bit, add a little bit more. And it's like sometimes we actually overshoot it. And again, look out for side effects. The side effects we see are odd motor movements, sometimes shuffling, pacing, tremors, facial tics. Sometimes people talk a lot about antipsychotics causing an increase in appetite. In people with PWS, that is definitely a concern. But their appetite is already pegged usually. They're hungry all the time. We find people with, like again, on a low dose that do quite well and their weight does not go up. Tardive dyskinesia is a weird side effect that happens with some antipsychotics. It's usually at a higher dose. So usually you can lower the dose, but you're always trying to figure out effective treatment versus lower dose and side effects. So it really is a balancing act. And so when I have people say, well, so-and-so gained 5 pounds and I'm really worried about that, I'm like, they're not psychotic. They're not crazy. We can live with 5 pounds, right? So it's this idea of like balancing that. Be vigilant, looking for side effects. And when doses or meds change, be on the lookout for side effects. Sometimes they're really insidious and they happen kind of slowly. Look at the half-life of medicines to find out how long they're in somebody's system because people with PWS, again, tend to be pretty sensitive. And I'm going to talk a little briefly about genetic testing. There are some genetic tests that will tell you what kinds of drugs your kids metabolize well and which kinds they don't metabolize well. So CYP450 testing is something some people have already had. It tells you what medicines they metabolize, and it's kind of like a little handy map of ones to try, ones to maybe try, if those don't work, and then ones that probably aren't going to be really effective for your kid. Doesn't really tell you exactly what will work, but it tells you which meds are more likely to. So usually for insurance to pay for it, you have to have 3 medication fails before you can get insurance to pay. I've had actually both of my adult children have had that test done for various reasons, and we paid out of pocket. And if your insurance won't pay, it's usually a flat fee of $330, which was a great deal because it helps you in so many ways with medications that work and don't work, and the results could be helpful down the road. So Genomind is one, GeneSight is another. The little printout that they send you, it's sometimes 15, 16 pages. It literally has green. I always say green is go, yellow is slow, and red is a no. So generally I don't, if it's a red, it means significant drug interactions, like they don't metabolize them. Yellow is a low dose. You could definitely try them. So it's not a no, it's just a really low dose. And green means you can use as directed. So the most important things to know is not everybody with PWS and UPD gets psychosis. So don't worry if your kid is, I have several people with UPD that I've followed for 20, almost 30 years, never had a psychotic break. Even those with deletion can have psychosis. So don't tell yourself my kid's a deletion, they're fine. It can happen to them too. When stressors happen, you need to be on the lookout, trust your gut, but stick with facts, right? What I see, what I hear, what I know. I always like daily diaries, journals, anything that you can write down things. It's really a good way to keep your memory right and remember when it happened, how it happened, and what happened. Try to deal swiftly with things, but don't blame yourself. You didn't do anything wrong. There is something genetic going on that is causing these problems. It is not you, and it is not poor parenting. Medications are crucial to recovery and to prevent episodes of reoccurrence. You need to work as a team to best support your child. Keep a list of medications that you've tried. Can't spell apparently, doses, dates, and any side effects for your provider. I have people who go, my kid took a medication that started with a T, and I'm like, Trileptal. I'm going through all of them, and it's like, oh, Seroquel. I'm like, okay, write those down. I have people who tried the same medicine 3 times because they don't remember having taken it before. Think about what you're doing and keep those good records. I'm happy to take any questions. I'm going to stop my share now, and any questions.
Elizabeth, that was incredible. Thank you so much. And there are a ton of questions. So folks, keep putting them in the Q&A as we go along. The first question is, how often is psychosis linked closely right after a seizure?
That's a good question. I really don't know. I mean, so people with PWS are more likely to have seizures, right? So we know that. I have not seen anybody where that's been linked. So my thought is we sometimes see this weird, they call it a post-ictal phase of a seizure, where they're kind of odd. I've had kids growl and make weird noises and seem really out of it. That is different than psychosis. So I would say probably not related. So there's nothing to me that would necessarily make those two related. But it's something to kind of know that you may sometimes see some really odd behavior after a seizure because people aren't quite back to normal.
Great. Next question. Can illnesses or infections cause psychosis? My sister has had multiple instances of psychotic type breaks with UTIs, resolving fully with treatment. Or is that different?
Yes. In older people, we know that UTIs are real, like people say, oh, so-and-so's got dementia, and so-and-so's got Alzheimer's. Sometimes we find it's an untreated UTI. Absolutely. That's definitely a possibility. Always kind of rule out medical causes before you go down the psych path. It really is an important thing to do. And you're right, infections, especially UTIs, we have people that don't complain of any symptoms of any sort. And then all of a sudden you test them and they're like, their bacteria load is unreal. So yeah, get an antibiotic is a way easier fix than an antipsychotic, right?
It's much easier to find somebody to give you an antibiotic than a psychiatrist.
Totally.
All right. I have a 59-year-old sister who is obsessed with death. She constantly asks if people, I just lost the chat. Sorry about that. Asks if the people she knows are dead. When you ask her what makes her think of that, her answer is, I don't know. She's on generic Seroquel. Do you know what can cause these unusual thoughts?
So if they're new, then I would really wonder if maybe some of the medicines, maybe the dose that she's taking, maybe the amount that she's taking, maybe it might make sense. If it doesn't like if it's something she's always been interested in, and people with PWS are sometimes really interested in like horror movies and kind of really dark things. And my thought is I don't think that's all that odd. I mean, I think for them it's interesting, and they don't have the same association with death that we do. Like Like, whereas we see death as like a real loss and we really focus on the grieving process. I've had people come up to, like, the casket and they touch grandma's face and they do things and you just go, oh my God, they just don't have
I'm
that same
curious.
association. They're curious, like little kids. So I think it's really important to kind of know. But if it feels like she's really focused on that, I would really wonder about the medications that she's currently taking. Is it the best thing?
Great. Next question, is Risperdal one of the medications that help reduce psychotic attacks? So I know you spoke about this a little bit. Could you elaborate a little bit on that?
Yeah, so, we it's funny, our folks in the UK and other places use Risperdal pretty, like, they use it a lot more than we do here in the States. We still focus on a lot of other options, but in other places, they really do that. We've actually been looking, we've kind of been looking at our population that we've been following longitudinally. We find that people often take Risperdal for irritability and for aggression and just being kind of generally kind of cranky. And what we find is some of those folks never have a psychotic break. So theoretically,
Mhm.
it's a possibility that it's a kind of a prophylactic for psychotic events. I'm not saying it always will work, but it may actually help people. And we know that people who are on it don't necessarily continue to have those breaks. I have a young lady years ago, before we really knew any of this, she was a UPD girl. She had 9 psychotic breaks over a period of about 20 years. And
Wow.
because we didn't, every time she got better, they would take her off her medicine. Oh, what a nightmare. And then within a few months, she would become psychotic again. We didn't know enough. It was like the early 90s. We just didn't know enough at that point. But now I think the idea of staying on a medicine and kind of using it as kind of a way to kind of stabilize things is a real way to go. So I would say it's a good one, as long as they're not on a real high dose. If they're on a high dose, you have to really kind of balance that.
Mm. Next question, what is psychotic diagnosis? So what does that look like generally speaking? And is that a spectrum in and of itself?
Yeah, it kind of is a spectrum. So you have people who have more of the troubling thoughts and whatever else, and then you have people that are like hallucinating. They're hearing things. They're really not in reality. Have people have these conversations with people who are definitely not there. So it is kind of a spectrum. But look at it as kind of like a wave, right? If you stay on that wave long enough, you are going to continue to have increasing symptoms often. Like, people don't necessarily just kind of keep on that real low level, but there are people, like I said, that kind of odd thinking that we think of as part of PWS.
Mhm.
There are people where they have some of that to begin with. So we really try to tease that apart. So yeah, I mean, I guess it kind of is a spectrum. There's a lot of different symptoms and not everybody presents exactly the same way. You have to really look at baseline, what's different.
Great, thank you. If you can treat the depression/anxiety, does that reduce their risk of developing psychosis?
It actually does. And what happens for so many people is nobody sees that the anxiety and depression are happening or getting worse. And they're like, "Dur, dur, dur," and then all of a sudden psychosis, and then we start to treat it. So yes. And the nice thing about Risperdal is at really low doses, it actually works as a kind of a nice antidepressant
Mhm.
versus it's an antipsychotic. We think that because it hits serotonin so much harder than dopamine, it actually has a kind of a different effect than like Seroquel and Geodon and some of the other ones. They're really high dopamine drugs. We think people with PWS are pretty sensitive to dopamine. So what you sometimes see from those other drugs is that what we would consider a therapeutic dose, they have a lot more problems and side effects on those drugs.
Mhm. Yes. Will psychosis become less with age, or is it the medications, the routine, and the structure that
It's
helps?
yeah, it's actually the second. I mean, age is kind of a risk factor, right? We know the older you get, the kind of more likely you are, especially if you're UPD, to actually have a psychotic break. Like, I don't see a ton of people who are older who haven't had some depression, some anxiety, maybe a little, like, they're definitely kind of on the edges of that. So I would say that you don't really age out of it. Actually, a lot of the people I see who are doing the worst are the ones who are in their 40s and 50s,
Mhm.
because people just aren't aware that it's happening. They're just thinking it's PWS.
Because yeah, I see that very often with that age
Yeah.
group, and they've been that way for so long that it has,
It becomes their new normal.
yes.
It's not weird because this is what they've been like for 5 years. It really tears me up when people have been this affected and this impaired for years and no one's treated it. So,
My son was taking Risperdal, but the doc took it away due to weight gain.
mhm.
He's now on, and forgive me for mispronouncing this, esket escitalopram,
Yeah, so that's yeah, Lexapro. So that's what
oh,
that is.
okay. He's barely being tested for PWS, but he's still so hyper. What can be prescribed together with that for ADHD. I'm not sure who asked this question. It's anonymous, but I'm curious about does he have PWS or is he being tested currently for PWS? So if you could respond back with that, we'll come back to that question after.
Yeah.
Is it possible for an individual with PWS to have psychosis signs younger than the teen years?
I don't think I've really seen that. I did have a young lady who had a surgery and had like what looked like a psychotic event. We found out after talking to the mom and several other people, she had a reaction to anesthesia that looked like psychosis. She was 9. She had her tonsils and adenoids taken out. She didn't recognize her family. She thought she'd been abducted by strangers and
Oh,
she
that's
kept running away,
wild.
right? I know it was really awful. And the mom called me, and I've known this kid since she was little. They gave her a drug that actually counteracted the effect of the anesthesia, which supposedly was out of her system, but it definitely wasn't. And within 2 days, completely clear. So if somebody's younger, I would wonder if something else is going on. Is there medication on board? Is there something else that's causing that? And I would look at infection and something else first.
Yes. Would you be comfortable with us sharing the PowerPoint presentation?
Absolutely.
Great. Can schizophrenia develop in individuals with PWS?
I have not seen that. I mean, I've worked with, when I worked at a psych hospital, I saw a fair number of people with schizophrenia. It has a really different kind of course. And so my thought is no, but I do have a few families. I actually have 2 families who have schizophrenia and family history. They have a kid with a deletion and they seem to have some definitely have some psychotic features. Still doesn't feel like schizophrenia to me, but I think it's maybe a risk factor. So if you have a family history, that's really important to know. Same thing for depression, same thing for anxiety. If you've got that in your family, you kind of have that on top of PWS. So just know that sometimes makes symptoms worse.
Yes. Okay, the previous question, he was diagnosed with autism. He is being tested for PWS based on his clinical symptoms.
Okay. So, there for autism, a lot of the medications that I'm talking about for PWS work really well for autism. That's actually where we get a lot of our data. So people with autism often have Risperdal. It's really effective for temper tantrums and irritability and all that kind of stuff. So there are definitely some overlaps. So my thought is I think if you get that diagnosis, we know that people with PWS can have ASD at the same time. So I think that makes sense. We've often wondered if having ASD and PWS makes you more likely to have psychosis. But so far that hasn't really panned out. Like it doesn't seem like it's a direct correlation in any
Okay.
way. So I think it's really important to get those diagnoses and figure out what you're dealing with.
Mm-hmm. So my daughter was diagnosed with psychosis at 10 years old. She's been on Haldol for 3 years. She hasn't had a psychotic break, but it definitely affects her every day. Fearful and odd, especially with strangers. Gradually, she doesn't want to do as much.
I mean, I think it might that's awfully young, and I would really wonder if there's anything else going on, and maybe have a second opinion, maybe have somebody else kind of like talk to them. Haldol, I have a few people take Haldol often because nothing else seems to really impact those psychotic symptoms. Back in the day, that's what we used for everybody. So I mean, I've seen what that can do, and it's not an awful drug. It's just an old drug and it has some side effects. But I would just kind of wonder, are we treating her effectively? Is this working? Is there anything better than this? Like maybe she needs a combo. Like I said, maybe she needs a mood stabilizer. Like what else does she need? Because it makes me sad that she's so fearful and withdrawn. That's a hard way to live, especially for your
Especially
family.
at 10.
Yeah.
Are psychosis and bipolar sometimes confused?
Yes, we have a lot of people who think they have bipolar, and I'm like, no, you just got psychosis. So I think it's really hard because of that depression anxiety piece to kind of understand. And because people with PWS can kind of go from 0 to 60, it looks a little bit like mania. They're not grandiose and happy. They're kind of mean and coming after you kind of thing. So it's not the same thing. I think bipolar is really overdiagnosed in the US, but it's also really overdiagnosed in PWS. I don't think I have seen 2 people that truly have bipolar and PWS, not very many people. I just think we don't know what to call it, so we just call it bipolar.
Right.
If you treat people for bipolar and it's not, it tends to make them worse. So just know that the medicines for bipolar don't often work for psychosis. They sometimes make people more manic, more ramped up, and not great.
And I think that's very often why we see medications get increased.
Yes.
Yeah.
over and over because we don't know what to do. We're just throwing it's like throwing pasta at the wall. We don't know what to do. We're just throwing everything at it.
Mm. So my daughter gets lots of sleep, but it's poor quality. We've tried every stimulant in the book. She tolerates none of them. Her sleep neurologist wants to try Xywav, I think is how you say that, in order to get her more slow wave REM sleep. She's almost 9.
Hmm.
But her hypersomnia is severe and it's starting to cause issues.
Yeah. I don't know that drug, and I'm obviously not a sleep neurologist or a neurologist. So I would just say, maybe talk to them about that. Definitely something you could try, but I would really kind of wonder like, is it obstructive sleep apnea? Like, what exactly is her problem with sleep? Like, if it's something else, could you do CPAP? Like, is there something else you could do that's maybe not medication? But I would say that we have a fair number of people, and they're thin and they're young, and they just have tons of sleep problems. I think that's we don't know as much as we really should know. So hopefully, in a few years, we'll have more info on that. I just feel like sleep is just so important, and I don't think we know enough about it. But I would, you can always try it. And if you find out something coming back to PWSA and letting them know, try that thing and it was a great, or try that thing and it was a disaster, because
Right.
you get lots of crisis calls. And I feel like without knowing that, we're just kind of shooting in the dark, right? We
Yeah.
just don't know.
Mm. Okay, our daughter has UPD and she had a psychotic break after a knee dislocation at 14.
Hmm.
We've never been able to get her back. She's on lithium and now olanzapine.
Hmm.
When we started Zoloft, she did amazingly well, but began rectal picking after a few months. We took her off, but missed the happy lift she got from the Zoloft. Should we avoid Zoloft? Do you like gabapentin for the same effect?
Gabapentin doesn't have the same effect. I mean, it's definitely one that, it does a lot of amazing things. It kind of calms people down and whatever else. Zoloft may have been too high. And what I wonder is if you always get the magic space to begin with, I tell people, oh, so really what the problem is not the it's not the wrong drug. It was the wrong dose, because they seem to accumulate it in their tissues. And before you know it, they have the weird side effects. So maybe you could think of it again, but maybe at a much lower dose. So I would just say, Zoloft is a pretty cool drug. Like I said, I used to not really think it was all that great, but I've seen some people on the like 25 milligrams and they're doing amazing. So definitely one to consider. And it's hard, like you said, 14, and to have something medical happen that kind of started you on that path. And so it's just so hard to tease all that out. I
Mhm.
and I and I can't tell you exactly what, but Zoloft, it can be a really amazing drug for people with PWS.
Yes. Can digging in the rectum be a self-soothing activity?
It can.
Our
It definitely has
granddaughter is
like a
20.
sensory kind of like thing. There's a lot of things that it does, and so I tell people, like, I've talked to people who do it, but, generally it causes pretty significant damage. So I would just say, if you can find something to replace that behavior with, so another like self-soothing, like, I tell people, you can rub on your arm, like if there's something else that gives you the same sensation without causing damage. And
Mhm.
if you can, then I think you try to replace that behavior. But yeah, it is self-soothing. I think that it's you dig, it bleeds, you get that little endorphin rush, and it becomes very, very hard to break that habit.
Have you found medications for psychosis help with rectal picking or no?
They don't always seem to be related, so I don't know. I don't think so. I mean, I tell people that feels like a kind of a combo. I know Ann Shyman and I've had this conversation many times, like about it's a combo of like drugs and a behavioral kind of protocol,
Mm.
supervision, busy hands, not letting them in the bathroom for 20 minutes. Like there are things you can do that make that better. And really access. I have people who live in residential group homes where they're literally wearing Spanx, like they can't get anything because you can't get any traction. So you do what you got to do. And I think at the end of the day, it can really I've had people who've had like prolapses and all sorts of other things. So it can really be a slippery slope. So self-soothing, yes, but often causes damage.
Mhm. My child with deletion insists that she has schizophrenia because she sees and hears good voices and visions plus bad voices and visions.
Hmm.
However, a doctor said that it's too difficult to diagnose when a person has an underlying intellectual or developmental disability. Can you confirm this? Also, she has tried a number of medications, most of which don't help. One of
Mhm.
them did increase the voices, but she didn't want the good voices to be decreased. How do you
Hmm.
handle this?
Yeah, I don't know. And I would kind of wonder, like, it feels like one that maybe like really teasing apart what are the good voices saying? What are the, again, they often think their thoughts are voices, like they hear other, they think it's somebody else. I'm like, no, that's your thought. They're like, really? I'm like, mm-hmm. So you can maybe the scary voices, maybe you can find it like it may not even be just entirely a medication issue. It sounds like there's a lot of things going on here. I would try to tease it apart. The fact that she doesn't want the good voices to go away, like
Mm,
that's an interesting thing, and that doesn't feel like true psychosis. Most people who are psychotic don't really get good, bad. They just kind of it feels like it's like listening to 3 radio stations all at once. I'm trying to figure it out. The fact that for her it's so dichotomous, good and bad, I would get some more information and maybe find out a little bit more about like what they do, what they say, and see if you can figure it out. It may be a medication thing. It also may be something that you can kind of behaviorally deal with some of the issues that she's having.
great. Lindsay asks, what is a high dose? I think that that's probably hard to answer.
It is. I mean, I would just tell people like, therapeutic doses for people with PWS are sometimes half to a quarter of what somebody else typically would be taking. So again, it's not, and people always ask about weight. Psych meds aren't weight dependent. That's not how they're dosed. So I just kind of think, again, the lowest dose that you can possibly get on. Sometimes I tell people you can try liquids because you can do really kind of small micro dosing, and then you can make small increases. But most people like double it up or triple it up, and then all of a sudden we have all the side effects without any of the good benefits. So it's a balancing act. And again, I'm not a physician, so you have to talk to your doctor if you think it's too high. Can you lower it? Again, balancing what the benefit is with what the side effects are, because it really is a balancing act.
Yep. What are your thoughts on carbamazepine? Carbamaz
Yeah, so that's like I know that's like a seizure medication that is often used for mood stabilization. Again, a lot of these drugs at low doses can be really effective. So, like I said, that's not one I see a ton, but like I said, Depakote I definitely see pretty frequently, and Lamictal and whatever else. I mean, there are some that are in that same kind of family that work well. So again, some of the ones that we have talked about at low doses work really well. Doesn't mean you can't try anything else, but just know if you see the side effects or you don't see relief, it may not be the right drug for your kid.
So we've learned that the medications are a band-aid that won't work long-term as the brain becomes sort of immune to its benefits. Can you say anything about this?
I mean, they always talk about Prozac poop out, right? So you take
Yep.
Prozac and it's working great, and then suddenly you feel really darn depressed again. So there's definitely that's definitely an issue for psych meds. The nice thing is if you start out at those low doses and you go slow, what's so interesting is I've had people who've been on Lexapro or Celexa or whatever for 10 or 15 years that are really low dose. They just make those little tiny steps up. So my thought is it's all about like not shooting over the limit. I think when you do that, you kind of flood the system. It's almost like, when your car is spinning out and you just put your foot on the gas and you just flood the engine and you can't do anything. It's kind of that same thing. It's all about that fine tuning of very small little microdose increases and really looking for what the benefit is versus the side effects. So theoretically, yes, but I have people who've been on sometimes 20 years on the same medicine. So it can work. You just don't want to overshoot it, because once you do, there's kind of no going back.
Mm-hmm. Yes. What is the mechanism of or evidence that PWS kids respond more to the dopamine, like you were mentioning?
It's funny. Deepan's book actually talks a little bit about dopamine receptors. There's a whole chapter that I was just reading, and I thought it was really interesting. I've always thought it was really great. He actually had some data to back it up. But yeah, something about the dopamine receptors in their brain seem to be super sensitive. So I've always thought that, but when I read that, I'm like, see, I think I'm
What
right.
you're talking about?
But Dr. Singh agrees. But yes, I would say that, and I've always seen like with some of the ones that hit dopamine really hard, we see that activation and that real negative thing. I've had kids they pace and they can't sit still and whatever else. And once we go back to like a low dose of Risperdal, they're settled, they're calm, they just seem to be better. So again, it's really balancing the idea of what works and at a really low dose versus a high dose, which again tends to overshoot the mark.
Yeah. Could you give more examples about the obsession with others? My daughter has a huge obsession with her friend, where she constantly talks about her friend all day long and smothers her friend. I see
Yeah.
this quite a bit.
Yeah, it really seems to be a PWS kind of characteristic, right? Especially for kids with UPD, not always. There are a couple kids with deletion. They have a stalker-like quality. I think their idea of like identifying with people is they over-identify, right? they're my best friend, they're my only friend, I love them, and everything about them is like, it's a real obsessional thing. I always say you got to dilute some of that love, spread it around a little bit. So it, I limits, don't talk about that person, redirect. You can find it. They just get stuck in this like a gerbil on a wheel, man, and it just goes around and around. And then eventually they have no friends. People are like, okay, creeper, I don't want that. Like, it's really unfortunate. Like I said, and even for us, like I've had kids who actually become really obsessed with people who work for me, like young 20 somethings. It gets creepy and it gets weird. And it doesn't even feel like a romantic thing. It's really obsessional. So that is part of who they are. Your job is to limit exposure, limit the talk, limit the topic, right? You just can't talk about that person all the time. Give them a timer and you're done.
Done.
No
So
more Laura. We're done.
when we talk about psychosis, if that's not something that is part of their normal personality and it starts happening, that's when we need to be concerned.
That's when we need to, yes, exactly.
Okay.
If they're not an obsessional stalker all the time, then you want to worry when they become that way. So exactly right.
Right. Okay, so a couple questions about Lexapro. Does it cause weight gain? And if you've been on it for years, will it stop working?
Uh, I haven't seen the issue with weight gain on it, so I
Mhm.
would say no. People with PWS gain weight, right? Like it is part of the phenotype. So I tell people often it's not the med. I mean, but what's interesting is if we lower anxiety and anxiety is keeping your eating kind of at bay, sometimes when we lower anxiety, all of a sudden they're like, I feel happy. I would like, like they feel a little more hungry, a little more likely to kind of like take the brakes off. But at the same time, we have people who've taken it for years. So again, 20 milligrams is considered kind of like the top of the range. We
Right.
have a few people who've been on it long enough that they're taking 25 or 30. It's kind of hard
Mhm.
sometimes to get that prescribed. But again, they've been on it for years and it seems to be really effective. So I just tell people it's really starting at that very low dose, sometimes as low as 5 milligrams to start. So if you start there, you got a lot of rope before you get to the end of that range.
Right. So what are the best antipsychotics for PWS with psychosis? And then are you aware of any that don't cause that weight gain as a side effect? So I know you've talked about Risperdal, you've talked about Zoloft. Um,
hmm So, generally I tell people like there are a lot of drugs that are, and there are a few antipsychotics that are considered weight neutral. So supposedly you don't gain weight on them. They're the ones that hit dopamine really hard. And so we get again, some of the side effects, some of the negative interactions. So I tell people, if your kid has unlimited access to food or whatever else, you're going to have to stop that any way you look at it. Like that's something you're going to have to do. So I think it's really about, trying to really be thoughtful about what you're eating, how you're eating, and whatever else. But any drug potentially in PWS, right? I mean, they're going to gain weight a lot. So it's just one of those things we can't always loop it back to the drug. But
right.
the drugs that are often weight neutral are not as effective for people with PWS. So it is again that balancing act. I tell people 5 pounds, a little bit chunky. Like, is that really the worst thing if they're not psychotic? And
Right.
sometimes it's really not. It really is about balancing quality of life.
Mhm. So my son has PWS, anxiety, and autism, and worsening angry outbursts. He is recently prescribed a low dose of Zoloft, 25 milligrams, and a Risperdal PRN. Is it reasonable to try the SSRI only to begin rather than try both?
I really sometimes in combination they're really effective. Risperdal PRN is not a good PRN. Like you can't go, oh, I think they're getting angry. Here, let me give you some Risperdal. Like it doesn't work that way. It's a much better drug to work and be in your system and be on board and keep you less angry. And it can really be effective for irritability, anger outbursts, temper tantrums, again, at a low dose. And we have a fair number of people who take both of those drugs
Yeah.
really effectively, as long as it's not too much.
Okay, my daughter with deletion is obsessed with a boy that used to go to school with her. She thinks he's her boyfriend. She's approached other girls to tell them to stay away from him. And if the girls have a belly, she asks them, "Why are you pregnant from my boyfriend?" He's not her boyfriend, but she thinks so. She goes to Messenger and Facebook and constantly sends him texts or just stares at his profile. It's exhausting and annoying. Is this something that I should look for psychiatric treatment?
It doesn't feel like it's psychiatric, but I would say again, if this has kind of been her MO and she's kind of got an obsessive personality, again, limiting it. We have people who call and text and like just they cannot leave somebody alone. Generally, the boy is going, okay, that's creeping me out. Like they're not returning the thing. I think their idea of wanting a boyfriend and being loved and, they want that, and so they don't get that that is not how it happens. You don't just pursue somebody until they fall down and you jump on them like a wolverine. Like, that's not how it works. So I would just say, limit. You can only text him once a day. You might need to put some brakes on that. She can't, so you're as parents, you're gonna have to do that. And
Yeah.
as far as the girls go, I don't know. They say sometimes ridiculous things. I mean, it's silly, but it's like it's more the fact that she's basically saying back off. We need to broaden her interest so that she has friends and maybe some people are more appropriate than this person who literally probably doesn't even know who she is, right? He's like, I don't know who she is. She used to go to my school. So again, it's kind of helping her get some more outlets, some more social things so that she can get those needs met without, messengering him like 100 times a day.
Mhm.
Put some brakes on it.
What are your thoughts on lithium versus Depakote? My daughter, who is deletion and 16, has had 2 psychosis episodes over the last 3 years. She's now on a low dose of Zoloft and Risperdal. We added lithium and she's doing great. I'm just curious about your thoughts.
Yeah, I mean, some people do pretty well on lithium. Again, it has that kind of mood stabilization effects. As long as they're not on a really high dose, it can be effective. I tell people it probably doesn't help a whole lot. It probably doesn't hurt a whole lot. So if she's doing great, good for you. You have found the magic. So yay. Sometimes you just stumble upon it. So good for you.
Okay. Any data on marijuana as a therapy or CBD, THC?
No. People ask a lot about that. So there's no data in anybody with PWS. Do I have people taking it? Sure. Do I think that it's the end all be all? No. Sometimes they'll say, my kid is so much less anxious. I'm like, I'm seeing them and I'm just not seeing that. Like, I don't know what you're talking about. So again, could it? Maybe. I just think that THC would make me worried because, people who do that, you can sometimes lower the seizure threshold. You can sometimes lower psychosis threshold. So it's one that we don't have enough data in. So I tell people all the time, like at the end of the day, I'm very data driven. And so I have a hard time with things that sound, hoopy and all whatever. I think what we know, we know. I'm not saying you don't try it, but I have seen people, at least with CBD and THC, I've seen both of those things. I don't see them being a miracle drug in any way.
Right. I'm confused about meds causing weight gain in and of themselves, or that it increases food drive and weight is gained because food isn't secure. In a residential program where food is secure, we don't see the weight gain from meds.
Right. And I think that's exactly right. So if somebody is in a really well food controlled environment, even when they switch meds, we don't often see that. So I always tell people if you're not locking and doing all the things you should be doing, yeah, sometimes when you add a med, your kid may have, they just have more access to food or they have like a little less, they have a little bit more wherewithal to get it or whatever. But it's not necessarily the weight is caused by the med, it's usually the environment. So again, what are we doing? What do we need to be doing? What do we need to, how do we need to lock that stuff up?
So I hope this question isn't too broad, but advice for sibling getting prescribed at very high doses and providers unwilling to listen about PWS. So I'm guessing this is the sibling effect of feeling anxious about their sibling with PWS. Newly diagnosed, prescribed 200 milligrams of Zoloft on top of a dozen other current meds at high doses. My personal opinion, and again, I am not a physician, but a dozen medications for
It's scary.
that's a lot of medications.
Yeah, I mean, I had a kid years ago that definitely had psychosis. He was on 15 different medications. His mom sent me binders. Every time they added another drug, he became worse. The suggestion I made to her was to go home and actually work with her doctor to discontinue all of his drugs, get him to baseline. What do we got? He's now taking one medication and doing incredibly well. He had been awful for so many years. Don't let don't let them treat your kid like a guinea pig and don't let them do that. Generally low doses, fewer drugs. The more you put in there, the more polypharmacy and the more problems you end up getting. I would get a second opinion.
Our daughter says she's not sleeping well. She started Zoloft a couple months ago. She's at 25 milligrams. What time should she take it, in the morning or in the night, or what else can she take for better sleep?
Usually people who take Zoloft take it in the morning, but again, I would kind of ask her, like when she takes her Zoloft, within like a couple hours, does she feel more sleepy? It could be messing up her sleep. So I would kind of look, when are we giving it to her? What is it working? And I think really looking at sleep hygiene. So, taking a shower, reading a book, doing all those things. If she's gaming and whatever else, of course she's not sleeping. I have a 24-year-old like that. It's like if you're doing those kinds of things. So really coming up with a very kind of low stress, relaxing, zen-like sleep experience, and then maybe talk to your doctor about, what other things could we do? Could we do, chamomile tea? Like, could we do other things to kind of like, ease her into sleep? Because and some kids with PWS often say they don't sleep well. I can never really decide if they're really tired and that's really what we're talking about versus sleep quality. And maybe have a sleep study. Like if she hasn't had that, figure out what you got here.
Yeah. Our son has been on Seroquel since he had a psychotic episode 5 years ago. We want to add something for his angry outburst. Would Risperdal be a good option or something else?
Most people don't take Risperdal and Seroquel at the same time. So generally, like it's just too much of the same kind of drug.
Mhm.
I don't know. I would talk to your doctor and maybe ask about that. Could we lower something? Like, does it make sense to look at other options or whatever else? But, as far as angry outburst, Risperdal is really effective for that. I mean, it really kind of chills people out in a way that, like I said, good benefit, a lot less side effects than Seroquel. So again, I don't know what the dose is, but if he's on a fairly high dose, we sometimes see that real kind of agitated, like angry out, like kind of like that's how it looks. Maybe there's a possibility that, he can take something that will help and keep the psychosis at bay, but at the same time, kind of help with some of the anger outburst.
Great. During a psychotic episode, our 18-year-old son decided to lodge a complaint against 4 people for sexual assault. 2 of these people were not present and it didn't happen. There's a police investigation and his complaints will not be pursued as they were unfounded. How do we help him understand that the facts he mentions didn't really happen?
It's really hard when people are psychotic because to them it really did happen, even if even if it didn't, it to them, that is what they say. I don't think I would go there. I don't think I would I just think I would just say, I know you believe that thing. I know you think that thing happened, but the police, I would just kind of like redirect his attention. Like I wouldn't keep talking about it, whatever else. I hate that. I mean, it has happened multiple times, even when people are not psychotic, where they've lodged complaints or said something awful about somebody. It's really devastating, especially for the people that they said it about. Like it's something that's really hard to overcome. So I would just kind of, I hate to say it, leave it be and let it go, but redirect him and really focus more on the fact that that's what he thinks, but it doesn't mean that it's true.
Mhm. Well, and sometimes I find that once the psychotic episode is over, that attention that they're getting is very reinforcing for an allegation like that.
Yeah, and that's kind of what they're getting. And they're also the victim, right? They're
Yes.
people are like sympathetic and whatever else. Can you find a way to get that need met without doing that? And my thought is find some ways to do that where he's getting his needs met, getting the attention, but not for that.
Okay, so this is going to be our last question. Can you please give a better definition or a description of schizophrenia that helps one differentiate between schizophrenia and psychosis?
Yeah, so schizophrenia is interesting because it's very genetically driven. I tell people if you have somebody in your family who's schizophrenic, you have a higher than normal chance of having schizophrenia. If you have no family history of schizophrenia, it's very unlikely that you or your child will have it. Schizophrenia has a lot of once you get it, you kind of stay there. Meds may help, but it doesn't necessarily take away all the symptoms. People tend to have once they hit that psychotic break, they tend to be here and they stay here. People with PWS, psychotic break,
And then,
boom, they kind of do this.
yep.
And so my thought is schizophrenia, once you hit that first speed bump, you stay there. You don't necessarily get much better. And that's the real unfortunate part of schizophrenia. There's a little bit of overlap. We think some of the genes are the same, but the outlook and the prognosis is really different. And PWS with the right medications, people get better.
Great. Elizabeth, thank you so much for this. It was fantastic. There is one more question. I promise this will be the last one. So my 21-year-old with UPD currently takes Abilify, lithium, Depakote, sertraline, and clonazepam. We just added the Zoloft because of his physical aggression. We started at 12.5. We're not seeing much improvement. He had a psychotic episode at 19. We now have a family member going through chemo and are noticing high anxiety changes. Do we hold tight? As now it's hard to see whether or not the Zoloft is working.
I mean, he's on a fair number of medications and the clonazepam. I mean, I don't know. I would talk to your doctor and go, are we taking the best combo of drugs? If it feels like there's a lot of drugs at play here, it might make sense. And I know you're going through a lot of stressful things, so you have to kind of decide, what do you think you could do? Because if you think you need to hold still, you do what you need to do. But I think maybe revisiting at some point might make sense. He's on a fair number of drugs, and if he's having those anger outbursts, it makes me think something is not really working as well as it should.
All right. Thank you. Thank you to everyone who joined tonight.